It's an absolute honor and pleasure for me to be here today. And I've titled this talk, Lost Files, Barriers and Untold Outbreak Stories from the Global South. These are my disclosures. And I'm hoping that over the next half hour or so, I'm going to walk you through a talk with the following outline. So we'll start out by laying the scene, setting the stage a little bit, and talk about global outbreaks of infectious diseases and why they are an emerging concern. And we'll also spend some time going over what gets attention and what makes the news. And we'll share with you a story of a monkeypox outbreak in Cameroon, which I was involved in, and then sort of lead into discussing barriers to outbreak identification and reporting with a focus of what happens in the global South. I would also spend some time talking about how to overcome those barriers to reporting, and then I would end with some concluding statements. So as we all know, we are living under the constant threat of emerging infectious diseases. And, just in the last year, over 50 infectious disease outbreaks were reported by the WHO. And I've just highlighted a few of those here. And you can see that there are so many potential infectious diseases that are poised to either cause outbreaks in different parts of the world or also have pandemic potential and can actually affect multiple continents at the same time. We are in year 3 of a global pandemic, so it goes without saying that focusing on emerging outbreaks of infectious disease is something that we should all be paying close attention to. And I think that in recent years, actually, when you think about the last 40 years, thinking about the HIV epidemic, which has affected over 76 million people globally and has caused about 33 million deaths, I think that in recent memory, it's really the HIV epidemic that brought into focus the potential for infectious diseases to cause large outbreaks and epidemic outbreaks with far-reaching consequences in terms of the number of people that are impacted. And 40 years on, we can't say that we're done with the HIV pandemic because 37 million people worldwide are still living with HIV. And in the last year, we still had about 700,000 new infections from HIV. So very much still an active epidemic that is largely not yet fully controlled in certain parts of the world. Now, fast forward to 2019 and the emergence of COVID-19. In just 2 years, we are at a staggering 330 million infections reported globally and 5.5 million deaths and counting. And I think it's even more sobering when you consider that the numbers that are actually recorded and reported are probably gross underestimates because not everyone who's had a COVID infection has gotten tested, and not everyone who has gotten or has died from COVID has been recorded. So when you adjust for the underreporting, the impact of the pandemic that has been ongoing for 2 years is actually really, really significant in terms of the number of people that have been infected and the people who have died from the outbreak. When you think about the epidemics that we've lived through, I think it's quite fascinating to consider what makes the news and how things make the news. Oftentimes, what gets or ends up getting reported in the news usually has to do with when an outbreak is perceived as a bigger threat for countries that are more wealthy or more resource rich. And I just put on this slide an illustration of some of the headlines that have emerged in previous outbreaks. And you can see that when Ebola first emerged in West Africa, a lot of the reporting in the US media and also in the media across Europe was more about the perceived threat of Ebola to the West, as opposed to really focusing on what the impact of Ebola could be in the regions that were particularly affected at that time. And that has not been different when you consider what happened at the beginning of the HIV epidemic in the early 1980s, where it was also projected as a disease that was affecting a group that was ostracized at the time, speaking about homosexual men in the early 80s. And a lot of the headlines were more driven by hysteria and the fear of a group that was marginalized and disenfranchised. And that hasn't changed much, even considering what we are witnessing with the COVID-19 epidemic. When it first started in China, there were lots of anti-Chinese headlines that fueled a lot of xenophobia across the world. And you would think that, because a lot of this has been condemned, that it would not repeat itself in subsequent waves of the outbreak. But just thinking about the emergence of Omicron in November of last year, some of the reporting was also very racialized and also very xenophobic in terms of projecting Omicron as this variant that was coming from an African country. As you can see here, this really offensive cartoon from a Spanish newspaper that represented Omicron as virus particles in a dinghy crossing the Atlantic into Europe. Now, these are how a lot of what makes the headlines is projected, but really, in reality, not everything makes headlines. And I highlight here some of the epidemics and outbreaks that happened in the course of 2021, which I am sure many in the audience have hardly heard about. There was a large meningitis outbreak in the Democratic Republic of Congo that recorded about 2,600 cases and led to 200 deaths. Camps of refugees in South Sudan were also significantly impacted by a hepatitis E virus outbreak that resulted in multiple cases and is still ongoing. And fortunately, the mortality rate of that outbreak has continued to be low. And also, dengue in Pakistan resulted in almost 50,000 cases and 183 deaths. Now, why did these outbreaks not make the headlines? In large part, it's probably because these are outbreaks of disease conditions that would tend to be confined to countries that are low or middle income or resource restricted. And the perceived threat that these outbreaks would then become an important problem in countries that are more well-resourced is a lot lower, which makes them less of a priority to be reported. And you might actually see more reporting of, say, one case of imported monkeypox infection in the UK or in the US than you would see of a dengue outbreak in Pakistan that is impacting 50,000 people. And I think it's always important to highlight that even though these outbreaks may not make the headlines, they have tremendous impact on the communities that are affected and continue to smolder in the background, even if you're not hearing about them. And the burden of outbreaks of emerging infections lies disproportionately in countries that fall within the categorization of being in the global south. And the reasons for this are manifold. It's both a combination of growing populations, the impact of climate change as populations move and encroach on wildlife habitats, and the interaction between humans and wildlife, as well as the fact that these outbreaks are usually occurring in countries that have weaker healthcare systems and may not have the resources to actually carry out the surveillance that is needed to detect outbreaks on time, report them, but also have the resources to contain them so that the impact that they create is not devastating on the populations. you know. But even if we don't necessarily pay attention to all of these outbreaks that are happening uh, primarily in the global south, that doesn't mean that we are insulated from them. I think that COVID has taught us a very powerful lesson of just how interconnected the world is. It's not because an outbreak starts out in a refugee camp in the south of Sudan that I, who lives in Atlanta, is insulated from that outbreak, because the world is more interconnected through travel. And, you're very much at risk by outbreaks occurring in places that seem quite far removed from you. And, when you consider any pandemic or any large epidemic that affects multiple countries, I think it should not be lost to us that it ultimately always starts with a small outbreak. So we have to continue to have a heightened awareness of the fact that these problems do exist and we're not removed from them just because we're not physically present in the areas and the regions that are disproportionately impacted and affected by outbreaks. Now, I was fortunate really by coincidence to be involved in a monkeypox outbreak, or the investigation of a monkeypox outbreak that occurred in Cameroon in 2018. Now, monkeypox is a virus that causes disease in both humans and animals, and it was first identified as a pathogen in 1958. And this was identified in monkeys that had been imported for laboratory use. And since that time, it has caused outbreaks, primarily in parts of West and Central Africa, where it is thought to be endemic and circulating in animal reservoirs, mainly in small rodents and small mammals, and also in non-human primates. Humans generally get in contact with monkeypox through their interaction with these animal reservoirs, and oftentimes it is thought that these interactions occur either through hunting or through other interactions with wildlife, which may come through the encroachment of human habitation into wildlife locales. Now, transmission can occur between humans, but it tends to be less efficient from human to human. And that has kind of been a saving grace, because a lot of the human outbreaks have tended to be of smaller size because of this less efficient transmission between humans. So how did I become involved in this outbreak? I was working at Emory University in Atlanta and living in the United States when in 2018 when this happened. And a colleague of mine who was working in a regional hospital in the southwest of Cameroon reached out to me by WhatsApp on a fine afternoon and sent me the image that you see here on image C. This colleague of mine is aware that I'm an infectious diseases doctor. And he told me, I just received this 25-year-old patient who came in with what looks like a chickenpox rash. But this is the second person that I'm seeing in my hospital in the past week who has this skin rash, and I don't know what to make of it. And immediately on looking at the imaging, I called my colleague and I told him, well, I actually think that you might be dealing with a case of monkeypox based on the fact that the rash seemed to be quite classic. And he also described to me that the patient had other symptoms that would be more typical of monkeypox, such as enlarged lymph nodes and a high fever that are not exactly typical for chickenpox. And he immediately said, so what do I do? And I said, well, first of all, I would want for you to collect data on this patient in terms of who they are in contact with. And you need to collect samples and refrigerate them and alert the district, the provincial hospital of the fact that you have a suspected case of monkeypox in your hospital. And just to give you additional context, this part of the country is quite enclaved and is right at the border between Cameroon and Nigeria, kind of on the southwest and northwest end of the country. It's a region that borders a thick rainforest, and there is a lot of encroachment of the individuals that live in that region with the wildlife habitat. A lot of the people living in that region of the country are dependent on hunting and farming for their livelihood. And so it really sets the stage for zoonotic infections. Over the course of the next 2 weeks, he obviously received multiple other patients presenting with similar symptoms. And as you can see here in figure A, this was the case of a neonate, an 8-week baby born in a house where the family had consumed some bush meat. And this child was brought into the hospital with a similar rash. And a few days later, the nurse who took care of the baby also developed a similar rash. Over the course of the next weeks that followed, my colleague was able to collect the data on the cases that he got, collect information on their clinical features, and was also able to collect some samples from the rashes as well as blood samples from some of the cases. It took about 6 weeks from the time he reported to the provincial delegation to the Ministry of Health, sending people to that region to assist in any way in the outbreak investigation. And full credit to my colleague for really taking on the guidance that he got from our discussions and being very diligent in recording all of the information that he could get from the cases that were received in his district hospital on the exposures of these patients, on their interactions with other people, and on whether the people they interacted with went on to develop additional symptoms. Doing a lot of this work with no funding at all, on his own time, while having to run a district hospital, which is the only hospital providing care to about a population of between 10,000 and 15,000 people. Now, this just illustrates to you the map of where the outbreak occurred. And this is the Njikwa district in the northwest, southwestern region of Cameroon. And I apologize for the small font, but the dots that you see on the map are the cases or the suspected cases in the cluster that was recorded. And you kind of see that they all kind of cluster within the district. And this border here is the border between Cameroon and Nigeria. So really in a region where you have lots of crossings across the border, and you also have lots of potential for this not only being an outbreak that is limited regionally to Cameroon, but has the potential to spread into neighboring Nigeria. Ultimately, things sort of picked up, and by the end of May, beginning of June, the ministry ended up reporting all of these cases to the WHO, and reporting was put out alerting on a monkeypox outbreak in Cameroon. And these are just some of the pictures that were kindly shared by my colleague, illustrating the sample collection at the district hospital, some of the outbreak investigation meetings with the teams that helped investigate the outbreak. And here is a picture of my colleague right here who led the investigation, and the full staff of the Njikwa District Hospital that were all instrumental in collecting the data that led to the reporting of this outbreak. And this really just summarizes the sequence and the timeline of events from the first case that he discussed with me on a WhatsApp message thread, and then going on to collecting a series of cases and characterizing them and raising the alarm at the regional level, which was then transmitted to the Ministry of Health, and collecting and saving samples in the district hospital laboratory. And these samples were eventually sent to the referral lab in Yaoundé, and 2 of the samples were confirmed to be positive for monkeypox virus through PCR. And the Ministry of Health ultimately reported the outbreak to the WHO. So from identification of the first case to reporting of the outbreak, first case identified in March of 2018, and not reported to the WHO as an outbreak until June 5th of that same year. So a significant time lapse between when the outbreak was first identified and when it got a footprint kind of more on an international level. And it's important to point out some of the challenges of doing an outbreak investigation in that part of the country. There has been intense regional conflict in the Northwest region and Southwest region of Cameroon, ongoing for the past 4 years. And this outbreak really occurred kind of at a period where there was intense fighting between separatist forces and government forces in Jikwa district. And a lot of my colleague in dealing with this outbreak and having to investigate it was also having to deal with the real threat of attacks on the district hospital from separatist forces. And he himself was kidnapped and held for ransom while he was doing the outbreak investigation, a ransom that had to be paid off by his family. And he was eventually released and left that part of the country for security reasons later on in the year, because it just became too unsafe to be able to continue doing work in further characterizing this outbreak and continuing to report on it. And just to illustrate to you how difficult the terrain is, you're talking about lots of untarred roads. A lot of the transportation in that region is dependent on motorbikes or bicycles, and having to go in to highly forested regions to talk to people who may be contacts of people who have made it into the hospital. And all you have as your method of transportation is a bike on a dirt road, just further highlights to you some of the challenges in collecting data that informs on an outbreak that may be occurring in a place where the reporting is not as straightforward as you may think in other instances that where you have more resources. So me being very much immersed in the research world and just incredibly impressed by the work that my colleague and friend was able to do, I strongly encouraged him to make sure that he wrote up this case investigation once the outbreak had been alerted to the WHO, and that he got credit for the work that he had put in bringing attention to this outbreak. He had no experience in research and so needed a lot of support in terms of a writing team being put together. He was very willing and very interested in learning the ropes, and worked very hard on a manuscript with the support of myself and some other colleagues who were a little bit more experienced. But then we ran into roadblocks when we tried to submit and get this data published. We did submit the manuscript eventually to multiple journals. Some of them sent it out to review, but some of them did not even send it out to review. And again, of note, I think it's important to point out that all of the authors on the manuscript that we submitted were all local Cameroonian names. So this wasn't supported by a big university or a big funder. When the paper did get sent out to reviewers, some of the comments that we had were basically comments that we were unable to address because we just did not have the resources. I remember one of the reviewers noted the fact that one of the patients in the case cluster was a guard from a primate sanctuary that exists in that region. And he wanted us to go back to the primate sanctuary and sample the gorillas in that primate sanctuary and sequence any monkeypox viruses that we could find from those gorillas and see whether they correlated with the viruses that were isolated in the case cluster. Obviously, in an effort that was unfunded, you can see how that becomes something that is not very feasible to do. And then you factor in the fact that all of this work and characterization of the outbreak was done in an area that was very high risk in terms of the ongoing conflict, and that, in essence, asking the researchers to go back and do more work in terms of contact tracing, in terms of interviews, in terms of collecting animal samples, was essentially asking the researchers to go back and risk their lives. And I think that oftentimes there is quite a disconnect in the minds of certain reviewers who are quite removed from the realities on the ground in terms of what is feasible and a reasonable ask when you are reviewing a manuscript and an outbreak that is being reported from a group that obviously is coming from resource constrained settings. So after multiple attempts and a really frustrating experience in getting credit where it was due for the work that was done, we kind of, felt demoralized and abandoned the project. And, ultimately it did get published, but all of the data was then published by scientists in the referral lab in Yaoundé, in collaboration with French scientists who helped do some of the sequencing work. And my colleagues who did all of the outbreak investigation have still not gotten credit for all of the work that they did. They were never acknowledged in the manuscript. And we reached out to the journal and launched a formal complaint and reported this with evidence supporting that the people who had reported the outbreak in that journal had not contributed significantly to the data that they published. And till today, we have not heard back from that journal. So I think that this leads us nicely into discussing some of the barriers to identifying and reporting outbreaks when you think about the challenges that are faced, particularly in the global South. Now, there are significant healthcare worker shortages. Like taking the example of Cameroon, the ratio of doctor to patient is estimated about 1 doctor to 8,000 patients. Cameroon has a population of 25 million, but every year trains fewer than 200 physicians. So a highly underserved health population. And when you have 1 doctor for a district hospital that caters to 15,000, 20,000 people, imagine the added burden on their normal duties as a physician who has to take care of his patient population. If you add to that having to investigate potential outbreaks of infectious diseases, you can immediately see how challenging that ask can be. Oftentimes, outbreaks occur along borders between countries that are quite porous. As I illustrated with this example, this particular outbreak occurred on the border between Cameroon and Nigeria, and it becomes immediately apparent how easily these outbreaks can spread and actually cause significant local epidemics. The healthcare infrastructure is weak, and oftentimes a lot of these investigations have to be done in settings where people just don't have the resources to be able to do the proper data collection and data storage, and then transport the samples to an appropriate center to get confirmation of what might be a suspected outbreak. And remember, all of this is happening in the background of other important infectious diseases that disproportionately affect these regions, thinking about malaria, thinking about HIV, thinking about TB and other infectious diseases. And you're also oftentimes having to do this outbreak investigations, and in places where the cultural beliefs may not necessarily lend themselves to being open to that sort of investigation. And so you really have to tread quite cautiously in making sure that you're respecting the local beliefs while articulating the importance of maybe carrying out an outbreak investigation and reporting on it. And that just adds an additional layer into what you have to consider when approaching these scenarios. And of course, as I mentioned, sometimes you're having to do these investigations in settings where there is significant geopolitical instability and the implications of that for safety. And I kind of broached a little bit on the challenges that we faced in terms of publishing. And I think that, you know, publishing is supposed to be the most powerful tool we have to actually tell the stories of outbreaks and pandemics and get that message out there to the broader scientific community. And it is important because people can learn from ways in which outbreak investigations are done and use that for future outbreaks when they are faced with the same. But oftentimes there is a lot of gatekeeping and there is a lot of challenges in actually getting to tell that story. You know, even though now we have other channels like open access as well as preprints, science still isn't equitable because there are barriers at every stage to being able to communicate on important work that is done. One of the main barriers, obviously, is the cost of scientific publishing. Again, as I mentioned, going back to the example of the monkeypox outbreak in Cameroon that I just described, this was really led by local investigators who are not researchers and who did not have any grant funding or any meaningful support from the healthcare authorities. And in trying to publish this work, we obviously did not have the funding to get this work published. And I just illustrate here to make the point of just how prohibitive funding costs can be. Just last week, Nature Neuroscience, which is one of the leading publications in the field of neuroscience, announced their new article processing charges for open access at a whopping cost of $11,390. Now, there is no researcher that I know in Cameroon who has enough research money to ever aspire to being able to publish in Nature Neuroscience at that cost. And, you know, this is just one example, but oftentimes the costs just make it so that it is really hard if you're not very well funded to actually be able to tell an important story and get your research published in the broader space. And this directly is reflected in the percentages of where publications come from, with low-income countries only representing about 9% of science and engineering papers that are published around the world annually. And of course, there is gatekeeping. There is a lot that has to do with name recognition and institution recognition. You certainly have a higher chance of getting a paper desk rejected if it's a bunch of Cameroonian names with no institutional affiliation in the submission, as compared to, say, for instance, an outbreak report that's coming from a group of epidemiologists in Cambridge. And that usually is the direct result of unconscious bias, or sometimes conscious bias, that may view that the quality of the work and the research that is done in low-income setting is inherently inferior to what is coming from other settings. And what that usually translates into is that, you know, it's almost as though it's mandatory to need collaboration with researchers from high-income countries with recognizable institutional names to be publishable. And I think that that should not be the case. It should really be based on the quality of the work that is being submitted, the value in getting that work out there for the broader audience to read and to be aware of, and also really judging it on its merit, as opposed to on the fact that on whatever perceived impression you may have on the quality of what is provided, just based on the fact that you don't know the people who've written the paper, or their affiliation may be in Jikwa Hospital, regional hospital in Cameroon, which you've probably never heard about. And of course, we can't be complete in this discussion without talking about the very real fears of backlash with reporting. And I think we have a very recent illustration of that with the emergence of the Omicron variant in November of last year, which was initially reported by Botswana and South African scientists in good faith to alert the world to the emergence of a new variant of concern of SARS-CoV-2, but was also swiftly, rapidly met with backlash in the form of travel bans and other restrictions that negatively impacted the economies of the countries that had reported. So reporting it, even when you manage to get your data published and shared with the world, may not always be embraced as the positive thing that it is supposed to be, and doesn't exactly encourage sharing data and fostering open science and open data sharing. There is obviously the lack of mentorship, and it's important to recognize that oftentimes some of the frontline people carrying out a lot of the grunt work in terms of bringing outbreaks to light and reporting on them may not have the training of an epidemiologist. They may not have any formal training in scientific reporting. And this translates into a lack of experience in approaching the process of scientific publishing, a lack of mentorship, a lack of support in writing and data analysis, and obviously also a language barrier. A lot of the science publications are in English, but there is a significant proportion of sub-Saharan Africa that is French speaking and also speaks other local languages. And also, if you look at South America and Asia, there are lots of other languages that are not as represented as the English language in terms of scientific publishing. And it makes it very hard for non-native speakers who may not have had an experience in writing in the English language or may not speak the English language to actually communicate on their science. And also in terms of ownership, who gets credit for the work done. And I think that that is where the onus really lies on the people evaluating the research. When you get a paper from Cameroon or a paper from South Africa or a paper from Kenya, and the most senior authors on the paper are actually people who are American or Dutch or British, I think that you owe it to the local contributors to ask yourself the question, or ask the researchers the question, are these people lead authors because they had the most funding, or is this really reflective of the contributions of those who actually did the work? Because oftentimes what this translates into is that the people who invest the work in time in doing the work and doing the grunt work are not always those who get credited for it. So how can we overcome some of these barriers? Just going back to thinking about the importance of outbreak surveillance, it's obviously important to strengthen healthcare systems because that would directly lead to a strengthening in surveillance. And this comes through providing funding, either both locally and through international sources, providing training that allows people to be more aware of the importance of reporting on outbreaks and how to do outbreak investigation, and also fostering data banking and data sharing. Now, you have to incentivize reporting, right? Because when you think about a doctor who is working or a nurse who's working in a district hospital and caring for hundreds of patients a day, and in addition to that work, they have to do surveillance work and report on outbreaks, that is extra work that has to be incentivized. Do they have the training? Will they get credit for the work when they report it? Will their reporting be met by backlash, or would it be encouraged? And will they receive support to control the outbreak? And as I mentioned, building stronger healthcare systems, providing mentorship, and incentives to retain workforce and really providing them the support that they need. Coming back on the scientific obfuscation side of things, making open access a reality. Like, you can't talk about open access if the cost of publishing open access is prohibitive and it ensures that only a small, highly privileged slice of the science world is actually able to publish in open access. And I think that we have a big part to play in holding journals accountable. When you think about the mechanism of scientific publishing, it is a multi-billion-dollar industry, which usually really comes to the profit of the people, the publishers themselves. And when you think about the model, the researchers do the work. The researchers do a lot of the peer review and quality control, and then they pay the journals to be able to publish their work. And institutions that fund the researchers also pay the journals to get subscriptions so that members of their institutions can have access to read the work that is published. So the model is clearly flawed. And I think that scientists have to hold journals to a higher level of accountability in terms of living up to what open access has to truly mean in terms of making research more accessible, both in terms of who gets published and who is able to read the research once it's published. And important for us as reviewers, when we are looking at work, especially work that comes from the global South, to think about who did the work, ask the right questions, ask the team publishing, where was the data from, who actually collected the data, and are they adequately recognized in this publication, to make sure that credit is being given where credit is due. And of course, decolonizing global health, which is really down to the power dynamic. It's not always the funders that should be able to dictate what gets published, what gets reported, but really the power should be balanced in terms of people in high-income countries and in low-income countries having the same access to being able to report and to also tell a story. So in conclusion, we are living with the threat of perpetual outbreaks, and underreporting continues to be a significant problem. A lot of the countries that are disproportionately burdened by these outbreaks are in the global South, and they face challenges at multiple levels when you think about how outbreaks are reported and communicated. It's important that we are all acutely aware of the real life challenges in bringing some of these outbreaks to the world and reporting on them. And it's important to recognize that the main ways in which we can overcome these challenges is through financing, providing the right infrastructure, and strengthening the human resources to actually enable proper tracking and surveillance. And in addition, the role of science in preventing reporting of these outbreaks has to be recognized and also confronted. It's important that we find the lost files and we tell the stories that do not always get told so that we can all learn from them. And I would like to thank, obviously, my colleague, Brice Sauer, the lead investigator of this outbreak, and one of the main reasons why I agreed to give this talk, because I'm still on the crusade that he needs to get recognition for the work that he did in leading this outbreak, for which he never really got credit for. And I'd also like to thank the staff of the Njikwa District Hospital in Cameroon, the Ministry of Health in Cameroon, and the Pasteur Reference Laboratory and the WHO. And I will leave you with these words, which are words from an African proverb, which say, "Until the lion learns to write, every tale would always glorify the hunter." And my addition to this proverb is that either the tale would glorify the hunter or it may not be told at all. And with that, I'll hand it over to the moderators. And thanks for listening. And again, thanks for inviting me to give this talk.